Hello, friends. So I'll be talking on this topic, septic cardiomyopathy. So I gave this talk as part of sepsis workshop in indoor intensive care conference. So I wish to acknowledge my colleague, Dr. Amrita, who helped me develop this content. So it's a brief overview on what an intensivist need to know about cardiomyopathy that happens in sepsis. So I'll just talk about a bit of a background and the physiological changes that happens and the approach to management. So it's a brief overview. So the septic cardiomyopathy as an entity was first described as late as 1984. So it's not a very old. So just about 3 decades back, it was described by Parker et al. By doing radionuclide sign angiography. And this he explained in 20 patients where LV dysfunction was present in 65% of the patients in sepsis. And a similar one was reported later on by Jardin et al. From the French group. So Nathanson et al. Later on did show that in all patients with septic cardiomyopathy, that LV contractility would be depressed. So that is the key thing. And not necessarily they would respond adequately to the fluid boluses or fluid responsiveness is something that will not be well present in these patients with septic cardiomyopathy. And it was later on shown. So the whole concept of the septic cardiomyopathy is way back in 1980s, people were trying to use PA catheter to ascertain the cardiac function, and they were not able to ascertain the myocardial dysfunction that was existent in septic patients. So when the echo uptake started happening, so then the whole thought process was that myocardial dysfunction or septic cardiomyopathy was able to better characterize with the echocardiogram, because before that they were depending more on PA catheter to ascertain the cardiac indices. So echocardiogram really gave a virtual sort of a picturization and ability to characterize the myocardial dysfunction or cardiomyopathy, which got well recognized with echocardiography. So there are different mechanisms as to why in sepsis myocardial dysfunction or cardiomyopathy happens. And the whole mechanism is attributed to the cytokine storm. So we all understand that there will be a lot of cytokine release that happens in sepsis. So the cytokine activation was shown to be one of the basic reason as to why cardiomyopathy sets in. So in the setting of sepsis, so there is increase in the circulating cGMP and nitric oxide that leads to activation of the cytokines and its effect on the myocardium muscle, leading to cardiomyopathy. And the shortening of the myofibrils or the cardiac myocytes significantly diminishes in patients with sepsis and in septic cardiomyopathy. And this reduction of shortening of the myocardium fibrils is facilitated or accentuated by tumor necrosis factor alpha and interleukin 1 beta. So I'm sure every intensivist would know that TNF alpha is one of the common sort of a variable that is purported to cause a lot of deleterious effects. And it is also shown that in sepsis, due to cytokine activation and due to activity of this TNF, there is mitochondrial dysfunction also that happens. So all in all, which leads to myocardial dysfunction and cardiomyopathy. And so this group from US showed that the myocardial response to the calcium is significantly reduced in sepsis. And this leads to increased phosphorylation of troponin I that happens in septic cardiomyopathy. So this is in brief about the mechanism. Basically, the key essence to remember is cytokine activation leading to myocardial depression and shortening of the myocardial fibrils get diminished, and this is accentuated by TNF alpha. And the myocardial response to the calcium is also diminished. That leads to increased phosphorylation of troponin. And you will see later on in the course of this narrative that troponin I, that's why would almost always go up in many patients with septic cardiomyopathy. And this is something that I'm sure many of the intensivists would have recognized, that troponin I will be high in sepsis patients. And that may be a surrogate marker of someone having myocardial dysfunction or cardiomyopathy. So what are the main characteristics of septic cardiomyopathy? The key aspect of septic cardiomyopathy is it happens acutely and it is a reversible. So the study done by this French group in 90 patients showed that in almost all patients, in 90 patients, the LV which was diminished due to septic cardiomyopathy, improves on its own in matter of few days. So this is something that is well recognized. And the other key aspect of septic cardiomyopathy is LV is depressed. LV function is depressed, but they can have normal filling pressure or it will be low filling pressure. So unlike cardiac event, so any patient with a acute coronary syndrome or cardiogenic shock, LV will be depressed, but you will see high filling pressure. So LV filling pressures will be high, but in septic cardiomyopathy, the key differentiator is they'll have normal filling pressure or low filling pressure. So these were the two studies where they showed that pulmonary artery wedge pressure, which is a reflective of the LV filling pressure. Now we can do easily the pulmonary artery wedge pressure or the left atrial pressure in the echocardiogram. So when they used the pulmonary artery catheter, the pulmonary artery wedge pressure was 14, which was not very high in patients with septic cardiomyopathy. And this was another study by France where they showed that the pulmonary artery wedge pressure was only 11 millimeter mercury, and that was also not very high. So all in all, showing that the filling pressures are normal or near normal in patients with septic cardiomyopathy. And another study, again, they showed that RV dysfunction also can be significantly present along with the LV dysfunction. And this was a study by the Belgium where they showed that the RV dilatation happens in 30%, which was recognized when they did transesophageal echo, that RV dilatation was significantly present. And RV dysfunction with pulmonary artery hypertension also was present in these patients. So in summary, so the key aspects of septic cardiomyopathy is it is acute, it happens acutely, and it is reversible. Reversibility happens in few days. And the key aspect is they have depressed LV function, but the filling pressures will be normal or it can be low. And many of these patients can also have concomitant RV dysfunction. And that is the reason why the filling pressures also is not higher in these patients, which we'll talk. So what is the reason? Then the question is, how is it that in acute coronary syndrome, the LV function is low with high filling pressure, but in septic cardiomyopathy, LV filling pressure does not go up? The reason is because of increase in the LV compliance in the septic cardiomyopathy, and percent of the patients with septic cardiomyopathy were shown to have LV dilatation. So LV gets enlarged and the compliance improves, and that is one of the reasons why the filling pressure does not go up, because when the compliance increases, it is able to accommodate that extra volume. So the filling pressure does not go up. So there are studies to show the type of changes that happen in septic cardiomyopathy. So the Parker et al., who was the first one in 1984 who recognized this. So they divided the patients into two groups, and what they found is in patients with sepsis who have decreased LV ejection fraction, the LV end diastolic volume, so the increased. So which typically tells you as to why the filling pressure does not go up or it is low. Because as you see in patients with depressed LV function, LV end diastolic volume was significantly higher compared to the ones where there was no increase, there was decrease in the LV ejection fraction, and that was statistically significant. And this was another study by French group. Again, if you see all these studies which I'll be showing you, any septic cardiomyopathy where there is depressed LV function, the LV end diastolic volume is higher than in patients where there is no depressed LV function. And this was Jardine et al. Again, LV end diastolic volume is higher in patients with depressed LV function as compared to the ones with preserved LV function. And this was statistically significant. This was another French study, which again shows that LV, where the LV ejection fraction was low, the end diastolic volume was higher as compared to where it was not reduced. And this was another. So all in all, 5 studies which tells you that any septic cardiomyopathy where LV ejection fraction is low, your LV end diastolic volume increases. And the last study, they looked at LV end diastolic area. That also was much higher in patients where there was depressed LV ejection fraction as compared to the ones where it was preserved LV ejection fraction. So this was another study where they gave an endotoxin and they looked at the response, and they found that the LV function got depressed and there was a reduction in the pulmonary capillary wedge pressure and LV end diastolic volume index. And there was 15% increase in the LV end diastolic volume by administering fluid boluses. So which means to say that in septic patients, when there was an induced sepsis in animal models, they found that the LV end diastolic, the pulmonary capillary wedge pressure and LV end diastolic volume index ratio comes down, and there is increase in the LV end-diastolic volume by about 15% as a response to the fluids in these septic patients. So this was another series of study looking at what timelines that LV dysfunction happens. So the incidence of septic cardiomyopathy in sepsis ranges from 18 to 65%. So in this study, the first study by Parker et al., the septic cardiomyopathy was recognized on day 1, and it happened in 65% of the patients. The Jardin et al., which is from the French group, so they looked at 0 to 6 hours, and 29% of the septic patients had septic cardiomyopathy. This was a French study where again they assessed the patients at 0 to 6 hours, 18%. So which means to say very early on in the sepsis itself, that septic cardiomyopathy or the myocardial dysfunction sets in this patient. So 18% had cardiac dysfunction. And this was a study where they looked at day 1, day 2, day 3, and in 3 days, 60% of the patients had depressed LV or septic cardiomyopathy. And this was another French study where 46% of them had septic cardiomyopathy recognized within 12 hours. So all in all, this table basically shows that septic cardiomyopathy happens anywhere from 18 to 65%, and it happens very early on, possibly within 24 hours in most of these septic patients. So if it happens very early on, and the range can be from 18 to 65% is what you can remember. And it was also shown that the timelines of the septic cardiomyopathy also is very dynamic in nature. It is not like it happens on day 1 and it remains same. As you see, they showed at 6 hours, 18% of them had LV dysfunction. At 24 hours, 40% had, and to 3 days, it increased to 60%, which means to say that it's an evolving sort of a pathognomonic feature. So early on it may manifest, and over course of days it may progress. So the number of patients who may have septic cardiomyopathy, one should be watchful up to day 3, where patients can develop this septic cardiomyopathy. So this is an interesting thing. I want to just throw this concept, which is very unique to sepsis, and it's very important. So in sepsis patient, although your LV ejection fraction is normal at 60%, they can still have septic cardiomyopathy. So this is a concept which even I felt was important, which we recognized. And this happens due to vasoplegia, because there is a reduction in the afterload, which means heart is beating against the dilated vessels, and they do qualify as septic cardiomyopathy. Although ejection fraction is normal, but there is vasoplegia. Because there is vasoplegia, heart is beating against the dilated vessels. It is septic cardiomyopathy. This also gets categorized as septic cardiomyopathy. So I've just put it in a very pictorial. So basically, your LV is beating against a dilated peripheral circulation, and that is also qualifies as a septic cardiomyopathy. And because we use norepinephrine in these patients, it unmasks the poor LV contractility, because you are using norepinephrine, you are constricting the vessels, but the heart is beating against the dilated vessels. So it unmasks this myocardial contractility, and your ejection fraction is overrepresented. So this is what conceptually we need to understand that happens in sepsis. And they have done a study from this French group where they've shown that patients with preserved ejection fraction, like figuratively as I'm showing, where LV is normal, but your vessels are dilated, they'll have reduced SVR, as opposed to the patients who have reduced ejection fraction. Where patients have reduced ejection fraction, SVR was not reduced as compared to the ones with preserved ejection fraction. And even they showed that patients with preserved ejection fraction over course of time, over 6 hours, 15% of them had supranormal LV ejection fraction, small LV, and increased cardiac index. The reason why this is important is they have recognized patients with septic cardiomyopathy with a normal ejection fraction have a poorer outcome as compared to the patients with low ejection fraction, because which is reflective of vasoplegic state where heart is beating against the dilated vessel. So this concept, I think one needs to be sensitized in sepsis. If a patient has a septic cardiomyopathy with a normal ejection fraction and with a high cardiac index, the outcomes were worse off than in patients where they had depressed ejection fraction with a normal or higher SVR. So this is what is a concept that I want intensivists to be sensitized to. And this is a beautiful figure, which I want you to understand. This was a series done in 183 patients. This figure shows distribution. So there are 4 phenotypes of patients, how each one behaves differently in sepsis. So pay little attention to this. So this is the first group. where they have depressed LV contractility with normalization of afterload, which means there is no vasoplegia. Vasoplegia is corrected with fluid resuscitation or vasopressors. There is normalization of afterload and tachycardia responses. This is one group of patients who behave this way. Then there is this second group of patients where they have left ventricular myocardial contractility with vasoplegia. So who possibly do worse off than the other patients. And this is the third group of the patients who have depressed LV contractility with normalization of afterload with hypokinesia, where LV becomes hypokinetic. And there is a fourth group of the patients where they have reduction in the LV contractility with RV dysfunction. So these are the four phenotypes or spectrum, how every patient may behave differently. There is one group where there is, so the common aspect amongst all these four is reduced LV contractility. But the first one is more favorable, where there is a normalization of afterload and there is a tachycardia response. And this is the worst of, where you have a reduced contractility with vasoplegia. So these patients have found to be having a worse outcome. And here they have hypokinetic, which you call it as stress cardiomyopathy or Takotsubo or whatever you may call it. And this is compensatory mechanism where you have RV dysfunction. So this is the four types how patients may respond differently based on the phenotype and based on the patient type, how they behave differently in septic cardiomyopathy. So very briefly talking on prognosis. So this is a very beautiful study. Again, re-emphasizing 67 patients, how patients with hypokinetic mortality was 43, normokinetic it was 24. And if you see hyperkinetic patients, the mortality was 100%. So which means to say, if you have a septic cardiomyopathy with a depressed LV function or ejection fraction, their outcome may be little better than someone where it becomes hyperkinetic. The best is to have normal kinetic, neither hypokinetic nor hyperkinetic. And to substantiate it, there are at least 4 to 5 studies. And it is shown that if someone has a persistent and profound vasoplegia, they have a very worse outcome. So these are some of the studies. So they have done a very beautiful sort of analysis of 200 patients. This is the survivor group and non-survivor. If you see Parker et al., survivor group LV ejection fraction was low as compared to non-survivors where LV ejection fraction was normal, and cardiac index also was better. And this was a French study. Again, you'll see all the studies where the patient group which had a lower ejection fraction had a better survivors. Here, if you see non-survivors had LV of 52%. And this is another study, again by French group, where LV ejection fraction being low, they did better in survivor group, and non-survivors had higher ejection fraction. And Kumar et al. From Canada, again there they showed survivors had lower ejection fraction, non-survivors had high ejection fraction. So this pretty much explains as to how we really do not want a normal LV with a vasoplegic state. We would love to have a normal LV with a with a with a normokinetic. So if you have depressed LV also, it may be better off than someone who is hyperkinetic and vasoplegia. These are the patients which do not do well, is what we can understand from all these 4 to 5 studies from these countries. So very quickly on the biomarkers, and I'm sure every intensivist listening to this would know that troponin I will be high in septic cardiomyopathy. It is shown that in sepsis, troponin increase happens from 43 to 85% of the time troponin increases. And these are the different studies. So this was a study by Vallabha et al., where they showed that troponin being high in sepsis patients may be a marker of mortality, hospital mortality, and 1-year mortality. This was another study where they shown that patients who have higher troponin fall in the non-survivor group as compared to the ones where troponin does not go up. And Masson et al. Showed that troponin increase on day 7 or more than 20% increase on day 1 to day 2 was shown to have increase in mortality. And it is shown that NT-proBNP levels is high in 98% of the patients with sepsis, and higher proBNP had a correlation with 90-day mortality. So all in all, this basically tells that septic cardiomyopathy or any sepsis where troponin is high, it may have some reflection of poorer outcome in these patients. And that is something that one needs to bear in mind. So just a last couple of 1 or 2 minutes on treatment. So when you look at the treatment of septic cardiomyopathy, so you can look into 3 broad categories. One is the fluid response, fluid resuscitation. use of inotropes and norepinephrine. So by giving fluid resuscitation, it may normalize cardiac index, but we have to be very watchful in not overloading the patient, because we have very clearly understood in ICU, overloading this patient with fluid can be deleterious. And it is shown that fluid resuscitation will not restore the LV function. It won't normalize your LV function. So you have to optimize the fluid status or fluid based on your fluid responsiveness indices, which is a separate topic in itself. But bear in mind that giving a lot of fluids also is dangerous, and giving fluids will not normalize your LV function. Dobutamine could be considered in patients with septic cardiomyopathy where there is persistent lactic acidosis, persistent shock, or patient who have oliguria to improve the cardiac output. Dobutamine is shown to increase the cardiac index and shown to improve the LV ejection fraction. So these are the two studies, Vallet et al. And Rhodes et al., who have used dobutamine at 5 to 10 micrograms per kg per minute, and they've shown it improves cardiac index, improves oxygen delivery, and these were associated with higher survival. And Kumar et al. Used 3 doses, 5 micrograms, 10, 15. And in his study, he pointed out that improvement in the left ventricular stroke index of more than 8.5 ml per meter squared led to good outcomes. So 21 out of 23 patients survived where left ventricular stroke index improved by 8.5 ml per meter squared. So dobutamine seems to have some role in septic cardiomyopathy, improve the cardiac function, improve the outcomes based on these 3 studies. And norepinephrine, as I said, is something that you would be using in all sepsis patients. But bear in mind, use of norepinephrine will unmask your myocardial contractility, and it may give you a sense of comfort that LV is beating well against a vasoplegic state. So if you have a normal beating LV and patient hypertensive in a vasoplegic, that may be a reflection of poorer outcome in this subgroup of patients, because that also gets characterized as septic cardiomyopathy with vasoplegia. So that is something I want the listeners to bear in mind. So the conclusions. So septic cardiomyopathy, one should know that the LV function will be depressed with normal filling pressure or low filling pressure, which is different to cardiogenic shock or ACS, where the filling pressures will be high. And key thing to understand is the reason why there will be normal filling pressure is improvement in LV compliance, or it is compensated with RV dysfunction. So because there is concomitant RV dysfunction, your filling pressure does not go up. And septic cardiomyopathy is always acute and it is reversible. The whole cardiac function normalizes in days. And please understand that septic cardiomyopathy is also referred to where cardiac contractility is diminished with vasoplegic state, where heart is beating against a dilated vessel. So that is something I want you all to understand. That also characterizes or get categorized as septic cardiomyopathy. And if someone is in a hyperkinetic state with a normal LV ejection fraction with a vasoplegic state, these are the phenotypes of patients who have a higher mortality. And dobutamine response seems to have prognostic value. If you have to subscribe to the study, Kumar et al., if your LV stroke index increases by more than 8, so if there is a response to dobutamine, that may lead to better outcome in these patients. And echo remains the tool for characterizing these patients with septic cardiomyopathy. So this would be the conclusion. So thank you one and all. So you can rehear to this lecture by visiting to my website, www.pradeeprangappa.com. So thank you one and all.